From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we discuss management of hearing loss, including treatments when hearing aids aren't enough. Our guest today is Dr. Jack Wazin, the Medical Director of Otolaryngology with First Physicians Group at Sarasota Memorial. Dr. Wazin, thank you so much for joining us.
Thank you, Allison.
An important question to start with for this discussion today is, at what point should a person seek out a specialist if they have concerns about their hearing?
Anytime somebody has concern about their hearing, they should seek a specialist. They should get the hearing test and get at least a baseline as to what is their hearing level like. Sometimes it's very mild, sometimes it's moderate, sometimes it's severe. More importantly, if there is a discrepancy in the hearing between the ears, if one ear is different than the other, you must seek advice.
Can hearing impairment cause cognitive decline?
Allison, this is a hot subject these days, and you could see it written in the lay papers and in magazines, as well as in the medical. It does not cause cognitive decline. It accelerates cognitive decline, and it interferes with the treatment. Because once you lose hearing, you automatically start withdrawing, and you do not communicate with your environment anymore. And if somebody is suffering from cognitive decline, they need more communication. They need to stimulate their brain constantly to work, to speak, to listen. Otherwise, the withdrawal creates more and more cognitive decline. And that's what we see happen with people who have different types of cognitive decline, including Alzheimer's.
Aside from cognitive decline, can hearing loss also cause depression?
It does. Hearing loss causes depression, social isolation, and withdrawal. And, if you notice people who are hearing impaired, or if you have somebody in your family who's hearing impaired, they stop communicating. At the dinner table, they don't want to participate because they misunderstand or do not understand what is being said, and sometimes they feel foolish answering the wrong question.
Are there any other reasons you recommend that patients get hearing loss at least tested or treated early?
We all accept the fact that as we get older, we get yearly physicals, we get EKGs, we get blood tests, and so on. A hearing test is a measure of another body function, the function of hearing, and how important hearing is in our life. It is very important, not only as a communication skills as humans, but also as a safety skill. You want to hear danger around you. You want to hear people talking. You want to hear a whisper. You want to hear a scream. You want to hear a truck. You want to hear a door. So all of that we take for granted. So why don't we respect that sense of hearing and check it once in a while to make sure that we're still in the right range? When hearing loss happens, it happens so slowly that usually the person who is suffering the hearing impairment are not aware of it as much as their spouse or children and so on. So typically, they're the ones who are pushing people to come and say, please get your hearing tested because I don't think you hear well.
It's not just age that can cause hearing loss, though. There are a number of causes of hearing loss. What are some of the other very common ones?
You could be born with hearing loss. Right now at Sarasota Memorial, we have a program of newborn hearing screening. Every newborn in this hospital gets hearing tested before they are discharged from the hospital. So hearing loss can happen from birth, after birth, and any time after that, from trauma, from infections, from genetics, from loud noise exposure.
How can you determine the right treatment for the right patient based on the fact that the cause of their hearing loss may be different?
Well, let's define two different types of hearing loss. A hearing loss could be what's called a conductive hearing loss, which means there's a problem in the mechanism of hearing. The small bones of hearing are not vibrating well. The eardrum is not vibrating well, and therefore sound cannot be transmitted to the inner ear. That causes a conductive hearing loss. Those type of hearing losses are typically fixable surgically. The other type of hearing loss is called sensory neural hearing loss, or what the public refer to as nerve loss. That is due to a weakness within the cochlea, which is the organ of hearing, or the nerve that is conducting the sound from the cochlea to the brain. So, how do we determine the difference? The audiogram is the first diagnostic step. It tells us what kind of hearing loss we have, and it tells us the severity of the hearing loss. Is it mild? Can we live like that? Is it moderate? Do we need to talk about hearing aids? Or is it severe? Do we need to talk about implants?
Do most patients start with hearing aids?
Yes, most people with hearing loss start with a hearing aid unless the hearing loss is so profound that the hearing aids are pretty much useless. And what we see happen is as you start with the hearing aid, and we're talking now about the nerve loss, the sensory neural loss, that is progressive. That worsens over time. And people get their first pair of hearing aids, and a couple of years later, they get another pair, and so on. There comes a time when hearing aids are not enough anymore because the severity of the hearing loss goes beyond what a hearing aid can offer. And that's when we start talking about implants, cochlear implants, as the answer.
Can treatment like hearing aids prevent the progression of hearing loss?
Unfortunately not. It prevents the progression of the cognitive decline. It prevents the depression and the social awareness and withdrawal. But if the hearing loss is occurring, particularly genetically, that's going to take its own course. The one thing that is preventable in hearing loss is loud noise exposure. So if you are exposed to loud noise during your career, if you work, at the airport or in the subway system or wherever there is loud noise, in factories, construction workers, there is significant hearing loss that comes with those type of professions. And if you stop the loud noise exposure, you could preserve more of the hearing until age takes effect.
Has the availability of hearing aids over the counter now helped patients, helped people regain some of that hearing?
Well, we're very excited that we have the availability now of the over-the-counter hearing aids. Now, over-the-counter hearing aids are not the real deal. Okay, they're mild amplification. They're not customized to the level of your hearing loss. They're not customized to the frequency of your hearing loss. But they're a good start for people who are wondering, do I need a hearing aid, to get started at a cheaper level, at an entry level. But we are not surprised that sometimes when people try the over-the-counter hearing aid, they realize that that's not the answer, that a customized hearing aid is the better answer, particularly in moderate to severe hearing loss. The mild hearing loss, you could deal with the over-the-counter. Moderate, severe, you need a prescription one.
So let's say a patient comes to you, they say, I tried these over-the-counter hearing aids. They definitely helped, but it's not enough. What's the next step?
The next step is we refer them to a hearing aid dispensing audiologist or a specialist, and they, with our prescription, which is the audiogram, will fit them, and everything is computer-based. They fit them with a custom-made hearing aid to the level of hearing loss and to the different frequencies of the hearing loss. You cannot amplify all the frequencies. So if you have a hearing loss that gives you normal hearing in the low pitches, but you lose the high pitches, then you only want to amplify the high pitches. If you amplify everything, then it's too loud and nobody likes it. So it has to be customized.
You also discussed implants as a treatment for many patients. Can you explain what options there are and who might use each of those implant options?
Yes. Implants come as cochlear implants, and a cochlear implant is a device that is implanted behind the ear with a wire that goes inside the inner ear that stimulates the nerve endings inside the cochlea electronically based on what the external processor is sending in. Cochlear implants are life changers. This is what patients report. We take people from being severely impaired or deaf to hearing in a procedure that takes about an hour. Outpatient, general anesthesia. We put in the implant, they go home. A couple of weeks later, they come back to our audiology department where we program the processor and the implant that allows the patient to start hearing. They hear birds, they hear speech, they hear people, they communicate. And that's good for babies. And now the FDA is approving implants down to age 9 months. We have babies implanted at 6 months, as well as 9 months and 1 year and on. The earlier we implant, the more normalized the baby and the child will be. They're mainstreamed. They go to regular schools.
Because it's different for people who might have grown up with profound hearing loss and then get the implants as adults, correct?
The earlier we place an implant after the onset of severe hearing loss, the better the outcome. So if somebody is born deaf and they come back at the age of 20 and say, I want an implant now, well, the chances are you will hear with the implant, but the speech is not going to be as good and the speech recognition is not going to be as good. So we like to implant people earlier in their history of deafness to give them the better outcome.
Now, I recognize you said it's an outpatient procedure, a short procedure, but are there less invasive options if someone is very against a surgical option as their first approach, let's say?
Other than the hearing aids, there's really no other options for the profound hearing loss. Powerful hearing aids, but again, powerful hearing aids, they're going to give you more distortion, more sound, more whistling. People know that there's somebody with a hearing aid whistling in the room. So when you reach that level, I think the cochlear implant is the answer. Now, there's a different kind of an implant that is much less invasive, but it's called a bone conduction implant, osseo-integrated bone conduction implant, if you can repeat that.
I won't try.
So that implant takes about 10 minutes, local anesthesia, outpatient, minimally invasive. That implant allows sound to go through the bone behind the ear, directly into the ear, bypassing any pathology that is happening in the ear canal or in the middle ear. So those people who cannot wear a hearing aid because they have chronic ear disease, cholesteatoma, which is a chronic ear condition, the absence of an ear canal, either genetic or because of cancer and so on. There are many reasons why people cannot use a regular hearing aid in the ear. That bone conduction device sends in the information, bypasses the conductive system, and goes directly to the inner ear. Works like a charm.
But that is better for those select patients that you discussed.
Correct.
Okay.
So there is a group of people who are better served with a cochlear implant. There's another group of people who are better served with the osseo-integrated implant, also called the BAHA implant. BAHA is for bone-anchored hearing aid. And there is a non-invasive hearing aid that is more powerful than a hearing aid, but not as powerful as an implant. It's called the ear lens device. And the ear lens device is no surgery. You asked about non-invasive. So that's one thing that kind of fits in that middle between hearing aids and cochlear implants. We have that ear lens. It works electromagnetically. So a piece of lens, and it's called ear lens because it's like the lens that people put in their eye, the contact lens. That contact lens fits on the eardrum. Within it, embedded, is a circuitry that absorbs electromagnetic energy that is coming from the outer processor. That drives the hearing system in a much more powerful way than a hearing aid does. And the gain in the high frequencies is much better. So when the high frequency loss is significant, those patients would benefit from that device before we even consider a cochlear implant.
How many patients do you see that the ear lens is right for? Or what diagnoses would you say, let's try the ear lens before we think about anything like an implant?
The nice thing about the ear lens or a hearing aid is that you could try it. You could try it in the office. You could put it in your ear and experience the difference. Even people who have hearing aids, if we believe that they would do better with an ear lens, we can present to them the difference and they could hear it. This is what your hearing aid is doing. This is what the ear lens is going to do. And then they could judge on their own whether the difference is worthwhile. But, I say it's like going from an AM station to an FM station. The richness of sound with the electromagnetic system, with more bass and more treble, more high pitches and more lows, makes the sound much more natural.
We know that a lot of people who have hearing loss, for whatever reason, avoid treatment early on. What do you think are the common misconceptions that people say, I don't want to seek a specialist?
People have these different resistance. They have a resistance to hearing aids, to the concept. At times I tell a patient, I need to get a hearing test. No, I don't want a hearing test. Why don't you want a hearing test? Because I don't want a hearing aid. I said nothing about a hearing aid. I said, I just want to test your hearing as a part of, examining your ears, your hearing system. Well, just the mere concept of a hearing aid sometimes turns people off because they don't want it. Why? I think there's a historical basis for that, because in the past, hearing aids were not as good as they are now, and the benefit was not as good. Two, there is a resistance because people think that if I'm wearing a hearing aid, I may look old or I may not look smart or whatever. Although people who do not need glasses sometimes wear glasses because they want to look smarter. Nobody wears a hearing aid because they want to look smarter. So it is those, and then cost has always been a reason, although studies were done in different countries, in England, for instance, where hearing aids are part of the national health system. People don't pay for them. Their use of hearing aids is no better than ours here in the United States, even though they do not pay for it.
What's your message to those in the community experiencing what they fear is the initial stage of hearing loss, or their loved ones are saying, oh, I don't think my partner or my child or my parent is hearing the way they used to?
Yeah. I'm smiling because the spouse of the person we implant are happier than the person we implant. They're it's, as I said earlier, it's a life changer to bring back to the world of hearing. There are people who are absolutely anti-implants. They feel like hearing loss is not a disability, and if a child is born deaf, then let it be. They'll go to deaf schools and they do sign and so on. That is not the majority of the public. The majority of people are hearing people, and to bring them back to the ability to hear and communicate, I think, is a very wonderful thing that we do. And it gives me goosebumps every time I see a patient after an implant of all type, and even after a hearing aid, when they come and they say, well, I'm very happy with my hearing aid, or I'm very happy with my implant. That's what we like to hear. That's what we like to do.
I recently rewatched the video that when I was with you early on in my career here at SMH with a child when they first approved the FDA giving to younger children.
Yes.
And we were there for turning on the implant, and it was such a profound difference for a young child, a year old.
Yes,
so
yes.
Does give goosebumps every time.
It still does me. You know, I've watched that video many times, and every time I watch it, you know, I get emotional because the emotions on the child's face and on the parent's face is amazing.
Absolutely. Is there anything else you'd like to add on this topic?
I think we touched on a lot of things. I think realizing hearing loss is important. Testing for it is important. Some people feel like, you know, I'm losing my hearing because I'm getting old. Not necessarily. Hearing and ears are an organ, and an organ failure needs to be measured and addressed, like a heart failure or an eye failure or a liver failure. When your ear fails, don't ignore it. And don't think that just going to buy a hearing aid over the counter without a medical evaluation is the right thing to do. So get evaluated, see the specialist, then decide if you want to go ahead with the recommendation or not. But do not ignore it. We see people who have large tumors, acoustic neuroma tumors. These are benign tumors that grow slowly, and the first sign of an acoustic neuroma tumor is mild hearing loss or tinnitus, and people ignore it. They go to their primary care. They go to their friends. I'm not hearing well. Oh, what do you expect? You're getting old. Not every hearing loss is because we're getting old. So it's a medical condition, needs to be diagnosed, the proper advice being given, and then you decide whether you want to do it or not. Nobody's forcing people into anything.
Dr. Wazin, thank you so much for your insight and for joining us today.
Thank you, Allison.
As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.